So this presentation is based on a collaboration that we've had with the Muhimbili Orthopedic Institute in Dar es Salaam, Tanzania for more than 10 years now. And it's called the Orthopedic Institute, but it also houses neurosurgery. So neurosurgery is part of the orthopedic group there, just so you understand a little bit of the background. And before I get started and go through the data, I want to thank some of the collaborators, obviously the surgical team and the anesthesia team at MOI. MOI is the Muhimbili Orthopedic Institute. Dr. Shabani, Dr. Rutab, Dr. Boniface, who run the neurosurgical and the anesthesiology program there, and are really obviously instrumental if you put this type of program together. Hal Mangat is a neurointensivist who is currently in London doing his master's degree, but he's a neurology and neurointensivist at Cornell. And then finally here, I have a picture of some of the fellows who really put all of this together. We have global fellows who spend a year in Tanzania. They're funded through patient donations from New York, and they help us collect data and make this collaboration really work on a long-term basis. So Tanzania, just for those of you who probably need a little bit of an introduction, is a country in East Africa. It has about 58 million people now. The median income is about $6,700, which I think is a little bit high based on, but that's what the data shows. It's high based on my previous recollections. There are now 17 neurosurgeons, but don't be fooled. Most of these neurosurgeons are in private practice. They're essentially all in one city. And at the university hospitals now, there are 10 neurosurgeons. And again, it's a country of 58 million people, and the neurosurgical care is really focused on 1 or 2 hospitals. That entails that patients obviously have to travel long distances if there's a problem, and especially for trauma patients, that there's a huge challenge. There's no centralized referral system, there's no ambulance system, and so forth. The main cause of head trauma, as you can imagine, is road traffic accidents. There's no ambulance system there. And so this is certainly no news for you. It's probably very similar here as well. Now, in terms of the background, just so you understand where those data are coming from, we've worked with MOI and with the university in Dar es Salaam for more than 10 years. I'm a neurosurgeon in New York, but I was very much involved with the Brain Trauma Foundation, and we did a big study looking at outcomes from severe traumatic brain injury in New York State. And I was very involved with the TBI track, which was the database that we used for this data collection. And it was then just a logical transition for me to ask BTF if we could use that database in Tanzania. And we've been using this now for more than 5 years. So that's a little bit of the background. The TBI track database covers patient outcomes at 2 weeks, mortality, and covers patient in-hospital data and data collection for 10 days. Now, in terms of background, again, at MOI, there was a small neurosurgical ICU that has now recently been updated, but there was no real protocol in place. And we have one of the nurses, actually, Nurse Sylvia is actually here in the audience. There's fantastic people who work there, but the challenge is really there's no protocol. The ICU is small, or was small, is bigger now, and was chronically understaffed. The program that we've been putting in place from Cornell is a program that tries to help teach and train neurosurgeons and nursing staff in Tanzania. And how do we do that without really being there physically? Or we're only there really 1 week a year. Well, we do that by having fellows. So we have fellows from Tanzania who come to New York. We have fellows from North America and Europe who we fund, and they go to Tanzania and spend 1 year there teaching, training. They really learn more than they're teaching probably, but that's the glue that really keeps everything together. And then we have research protocols. So we collect data on traumatic brain injury and spinal trauma, and I'll talk about spinal trauma later. The most important thing is, I think, are these weekly conference calls that we have where we talk about cases, about the research, and so forth. And then finally, which is a great thing for the local surgeons, we really work hard together to come up with publications, and we try to get our Tanzanian colleagues involved in the academic world as well. And this just some images of some of the fellows. So that's really where this protocol, where this project really came from. We just had a neurotrauma course in Dar es Salaam this week. It's still ongoing today, and we do those once a year. So about 5 years ago, we started introducing TBI Track, the database, into the hospital, and we include patients with severe traumatic brain injury within 48 hours of head trauma, which is different from what TBI Track used originally, which was only 24 hours. I just want to show you some of the highlights in terms of the data. Now we have 462 patients included in 5 years. These are the data from 2014 to 2018, and I'll show you the most recent data or preliminary data at the end. The mortality was a staggering 63%, okay, which is obviously very high. Everything else was pretty much as expected. Young patients, male predominance. If you look at the pre-hospital data, patients come to the hospital between 4 and 13 hours. Almost 90% of patients go to a different healthcare facility before they come to the main hospital. And obviously there's a relationship between Glasgow Coma Scale and mortality. About 55% of patients underwent CT scans, and they usually get one scan in the beginning. That's on average about 3 hours after arrival to the hospital. It's very rare for patients really, and that's where the resource limitations come into play. It's rare for those patients to go back and get more CT scans, but it can be done on an individual basis. You can see here that there was a relationship between patients getting that first CT scan and mortality. Mortality in those who got a CT scan was 50%. In survivors, almost 70% of patients who survived had a CT scan. And finally, abnormal CT scan findings were very closely related with mortality. In terms of patient management, most of patients, or pretty much all patients, were admitted to the ICU, so we didn't see necessarily this orphan effect, even though I think we probably should look into this a little bit further. Surgery was primarily performed for clear surgical lesions such as epidural, subdural hematomas. There was no ICP monitoring, and there was no real ICP-directed care. As I mentioned, these patients only got one CT scan in the beginning, and then everything else was really managed based on clinical findings. Mannitol was used in about 50% of patients based on clinical indication. Hypertonic saline is not being used. Interestingly, we did not find a close correlation or any correlation between hypotension and hypoxia, which is probably based on the fact that in the ICU it was very, very difficult to really continuously monitor these parameters. So that was somewhat interesting to see, but I think it doesn't mean that there was no correlation. I think it was just a effect of the poor data collection. There was a strong relationship, however, between those patients who had surgery and those who didn't. Having a neurosurgical operation was strongly correlated to improved or to lower mortality, these patients. Now, this is the 2-week mortality plotted every year over 5 years. And you can see here the mortality was always in the 60+% range. So I remember we had a meeting in Tanzania last year, and we looked at this and we said, what the hell, how many more years can we document a 60% mortality? At some point, there has to be a change. How many more years can you do this? And we always thought about, well, what would be the next step? The next step would have been implementation of protocols, get more CT scans, train the surgeons, the ICU staff, and so forth. But that was very difficult to do if you're not really there on a daily basis. We did a logistic regression analysis to predict 2-week mortality, and as you can expect, age is an important factor predicting 2-week mortality. The baseline motor score was significant. Finally, the presence of a craniotomy. Again, patients underwent craniotomy that had significantly lower mortality, and CT scan findings. So what happened then I'll give you a few discussion points. Now, if you look at the predicted mortality based on the CRASH trial, the mortality should have been about 43%. The observed mortality, however, was 67%, which is obviously much, much higher. One of the problems was the prolonged time to presentation, the lack of pre-hospital management, and the most important deficit, probably the ICU care that is limited, understaffed, there are no resources available, and so forth. So what happened now over the last year, since 2018, there have been significant investments made by the government into the hospital. And now there was a new ICU that was open, a 16-bed ICU and a 16-bed HDU. And that's actually run by Nurse Sylvia, who's sitting in the back here. And there has been some hiring of staff. They have 3 new anesthesiologists. They have now 24/7 resident coverage, which wasn't there before. And now they have multidisciplinary rounds every morning, which wasn't really there before. And that was really one of those things that was initiated by the visiting fellows. And they took that really to heart, and they really implemented these daily multidisciplinary rounds. And they have an in-house CT scan and MRI scan. So a lot of changes over this past year. And then if you look at the data, the mechanical ventilation rates went up, the CT scan coverage went up all the way on the right. Now, almost every patient receives gets a CT scan. And probably most importantly, the rate of surgery went up from 24 to 46% over the past years. Now, these are preliminary data based only on 10 months data collection, but it seems to be hopefully significant. And what we've seen again in a preliminary analysis now over 10 months was a decrease in mortality from 64 to 42%, which is quite encouraging. So I want to summarize. There's obviously a dramatic and really high mortality, much higher than the predicted estimates, at least over the first 5 years of this data collection, and probably associated to the many gaps that are based on limited resources and undertraining, understaffing. The most important thing, and I think where we can make a difference from outside Tanzania, is by capacity building. Twinning seems to be a very successful way of really improving neurotrauma care. So getting other universities, hospitals involved, and there's a lot of passion all over the world in doing that. But specifically in Tanzania, I think we identify the ICU as the biggest challenge, and that means the leadership of the ICU, the staffing, the training, implementation of protocols. Now we're at a mortality of 42%. Hopefully we'll be able to reduce that much more. Thank you for your attention.